Let me just, this is Diane Kuhn ready here?
I
Okay,
am.
excellent.
Can you hear me okay?
Yes, we can. So Dr. Kuhn's an assistant professor of clinical emergency medicine at the Indiana University School of Medicine. And she also has a PhD and graduated from Harvard. So she's very academic. Oh, and Johns Hopkins. So she's got hit all of the keywords for academics, and was a resident physician editor at the Academic Emergency Medicine, SAEM, basically. So Dr. Kuhn has all the credentials to stand up here and talk about academics in medicine, but also recognizing a lot of problems with the NPP world, a lot of problems with, say, the Jesse Pine study that came out with conflicts of interest. So how do you navigate academic waters and be effective? And thanks for joining us.
Yeah, can you guys see my screen okay?
Yes.
Yes?
Yep, looking good.
Okay, cool. So thank you to Dr. Lee and to everybody. I know there's been a huge team, and I apologize. I haven't been able to join much earlier just because I'm coming off a stretch of nights, but it's awesome to be here, and I'm really inspired by all of the work that everybody's doing. So like Dr. Lee was saying, I'm junior faculty at Indiana University and have kind of been doing the academic thing pretty much my whole life. So my niche is sort of how to have a marriage between the academic sort of within the system position with holding the beliefs and truly believing in all of the good work that this group is doing. So anybody know who this is?
Is that from The Wire, or am I just?
Yes. So I trained in Baltimore. So this is Omar, who is the Robin Hood drug dealer in The Wire. So this is, you know, basically how I was feeling about a year or two ago. You land that coveted academic job, you're feeling great. This is exactly what you have been training for. And you're thinking you're not going to ruffle any feathers. This is, by the way, Stringer Bell, who's another major character in The Wire. So you're thinking it'll be great. You're just going to kind of do your job. You're going to prioritize the patients, and you're not going to get involved in politics or controversial issues. Yeah, that's not going to happen. It's impossible. I had that thought too. I don't want to ruffle any feathers. I want to basically stay on everybody's good side. And that's, from what I can tell, just not possible. Because as an academic, you're essentially trading off sort of the faster paced community lifestyle for the privilege of having a little bit more say or a little bit more leadership in the direction of the profession. And ultimately that means your actions are going to be seen and viewed. And so you almost have to take a position, whether you like it or not. So if you're going to be doing research, what you research and the way you talk about medicine and topics in emergency medicine will garner attention. The way you talk to residents, the way you talk to medical students, the way you talk about the job market, the way you teach, the way you interact with non-physician practitioners, that's all going to be observed by learners in your field. How you practice, how you document, what choices you make when you're signing your name and coding and billing and all of those things, those are going to be observed as well. And inevitably, you have to engage with your department about issues, with your directors, with your hospital and institution, and all of those choices you make. You can say that you're not going to quote unquote be involved in politics, but then you're sort of choosing to engage on the de facto side of how things are. So this must be one of those entrapment things. So I've sort of developed a system for myself in terms of things that I am willing to do and how I'm going to advocate, and basically just a few first principles of ways to get involved. So the first is to make sure the motivation is right. So make sure that I'm not advocating out of insecurity or out of professional ambition or for some reason other than the profession of medicine and the care of patients. I think that's first for a reason. Make sure your method is appropriate. And the methods that are appropriate in academics, I think, are quite different than the methods that may be appropriate for, say, a social media influencer or a politician or a musician or somebody else. We work slowly, we work subtly, and if you want to be influential or impactful, I think you have to work within the rules of the system. The next one's a little bit difficult because it's hard to provide data that don't exist, and it's difficult to provide evidence that doesn't exist. But when it does, and if it does, you should have that available. And if the data don't exist, and it's something for which data should exist, that's also an important point to make. And certainly quality of care and different types of practitioners, physicians, non-physician practitioners, and quality of care. I think those are all things for which we don't have adequate data. And prioritize. So we've all worked with that person in the office who, is frustrated that the toilet paper roll ran out, and gosh, the coffee machine's broken, and the boss is sure a jerk, and the parking lot really needs to be swept, and everything is just not going well, and everybody's kind of out to get him or her, and you don't want to be that person. So you need to recognize all of the things that people are doing that are good, that are right, and all of the things that are going well, and then choose a couple of issues that you will engage on that you think there's room for advocacy. So that's how I'm approaching it and what I've kind of developed for my own system. So one of the issues that I've decided is personal to me, and I think deserves advocacy, is correct terminology. And Dr. Lee and Dr. Gallen, a few other folks that I've just heard brought some of these terms up, but I don't think physicians should ever be referred to as providers. I specifically don't think physicians should be referred to as providers, as though the two professions are nursing and providers. So this is a little bit busy, but I'll walk through them. So anytime in any profession, you're going to have a supporting team. So physicians have support in PAs, nurse practitioners, scribes. Nurses have support, MAs, techs, CNAs. So saying providers and nurses doesn't make a lot of sense. I mean, you could say providers and bedside providers if you really wanted to get sort of wrapped up in corporate business lingo. And I've heard, departments referred to as service lines and all that sort of things. But I think it's really important to refer to professions as their appropriate licenses for morale, for wellness, for patient transparency, and just to acknowledge that this is more than a business. This is not the healthcare business. This is a profession. Medicine is a noble profession, as is teaching and social work and nursing, and all of those should not be treated as sort of service line providers. So I think that terminology is really important. And I've, along with a few other people, have been writing to journals to develop editorial policies, basically taking providers out of the language that's used in the journal. So Dr. Lee referenced this article. I'm sure a lot of us are familiar with it, fairly splashy article that came out earlier this year on the impact of non-physician practitioner staffing. And essentially, if you go just by the data, what they concluded is when you decrease the level of training and expertise, so when you decrease the percentage of patients who are seen by physicians and increase the percentage seen by PAs or NPs, there was no quote unquote cost savings, or it didn't increase profits other than to decrease the number of people who are profit sharing. So I think I think that's extremely important. And it's also important to understand that the way that the article was written was very suggestive in terms of making it seem that there had been a very positive finding for incorporating nurse practitioners and physician assistants in the emergency department. And that kind of speaks to what I said about not being able to avoid politics, because when something like that is published that stretches beyond what I would consider the ethics of good research and publication, where conclusions are drawn that aren't merited by the data, you have to decide, are you going to, as a researcher, as a peer reviewer, as an academic, are you going to engage and make a comment and express concern about the research ethics, or are you going to sit on the sidelines and agree with the conclusions? So points of advocacy in terms of supervision, I in just the short time that I've been on the call, I've heard some of these already raised. So legal supervision, just jump into the middle, legal provisions in place that protect physicians when they're asked to supervise or review charts, ensure that they're given time to do so safely, I think is incredibly important. As Dr. Geller was pointing out, reviewing a chart 3 days later to find out that a patient wasn't told about an incidental finding isn't acceptable. It's hard to count the number of patients I've had to call back about incidental findings or vital signs or other things like that. And that's not true supervision. And, obviously if you're signing charts or somebody is signing charts who never saw the patient, patients should not be billed for that care. I've personally received an emergency department bill from a physician who never saw me because I was only seen by the PA. That's obviously unethical, and I would argue that's pretty much fraud. So I think that that's something that we absolutely have to advocate on. And this last point, that patients deserve a single high standard of care, I think Dr. Lee was sort of starting to speak to this a little bit, which is that if you have full practice authority for nurse practitioners and simultaneously say that the standard of care for nurse practitioners legally is lower than it is for physicians, which is the current, by case law, the current standard of care, then we're essentially saying that it's okay for some patients to receive a lower standard of care without ever consenting to it. And that doesn't jive with my ethics or what I understand of what we took an oath to. So I think there's some basic points of advocacy that really shouldn't be up for debate. And I think as academics, we really should be able to jump in on that and kind of say those are musts. And then I'll throw this in, this came up, we were kind of making reference to the lack of residency shortage in emergency medicine. This is charts not great, but basically, you can see very obviously that there's been a proliferation of emergency medicine programs in the last several years, and both sort of on a more objective data-driven scale, but also on an anecdotal scale. I think we all know that the quality of those programs in a lot of cases has been quite poor. So things that we need to be bringing up in academics and discussing with folks who are involved in leadership with national organizations involved with ABEM is that there's a thin line between service and cheap labor. One of the favorite expressions is, for residents to have a balance between service and education. I think you can do both of those things. You are providing service to patients as you get your education and provide patient care, but service shouldn't mean cheap labor. It can't mean that. And that's what it's become with some of these residency programs. And that hurts everyone because our certification's only as valuable as whatever corporate residency program has opened somewhere with, flying in people with no experience running a residency with residents who aren't truly getting taught. And there have to be effective ways for residents to communicate that to national leadership organizations. And those national leadership organizations need to be responsive when those concerns have been communicated. So for those of you who are Wire followers, you might know the character who played Omar just passed away this month. But I think this is really true. Whether you want to call it a code or sort of ethical standards or whatever it is. There's another line that I really like from The Wire by one of the police officers who says, you know, at some point you have to decide whether it's about you or it's about the work. And I think that we are all here because we feel it should be about the work and about the patients. And I think that there truly is a way in academics to make it about the work without sort of doing so in a way that gets yourself kind of thrown out of the institutional system itself, because I think that we do need advocates and allies who are kind of working within the traditional system. So thanks for having me. By all means, at any point, communicate with me. My personal email gets checked much more frequently than my professional emails. And I really admire and appreciate all the work that everybody here is doing. So that's all I got.
Thanks so much, Diane. Well, we are right on time here. I just actually accidentally closed my schedule. So I was looking at the next, see if we have any time coming up. Let's see, we are at 11:15. Oh, our little video break. Okay, so yeah, thank you so much, Diane. Honestly, this is something that's huge, and a big platform of Dr. McNamara is that we need academics to speak up. But as you know, I actually still haven't heard from Dr. McNamara how did he get to be a tenured professor while speaking his mind? Because I think that's one of the big keys, is not everyone is a tenured professor in academics. And so you are still risking something on your climbing that ladder. So this is very insightful and an excellent presentation. And I hope a lot of academics and hopeful academics really follow in your footsteps.